It is my privilege to be here at this meeting today and to be at the podium because Mr. and Mrs. Friesen, after whom the conference is named, were both patients of mine at one time. And it was just, I can tell you, a very, very sincere pleasure to know both of them. Both Mr. Friesen, who was always interested in so many things, and I can just hear him in the discussions today. And Mrs. Friesen, she lived a little bit longer than he did, and I had the privilege of having a meal with her and having a tour of her apartment. They had traveled over the many years and collected so many interesting things. So again, I really appreciate the opportunity for being here and also having been around long enough to know the people who have sponsored this meeting, which has been continuing in a growing way at Simon Fraser University over several years. I very much appreciated the presentations that we've just heard, and I have many things I'd like to say about that, but I won't, because we have a wonderful panel in front of us now. And the first speakers are from the Alzheimer's Society of BC. Jim Mann, I think, is no longer on the board, and he was on the board of the Alzheimer's Society of Canada as an amazing representative because of his thoughtfulness and provocativeness whenever he spoke, and I know he'll be doing that today. And Maria Howard is the CEO of the Alzheimer's Society of BC. And I think you are tandem speakers, are you? You're going to go first, Jim? And Jim Mann wrote a wonderful letter that was published in the Vancouver Sun, and maybe some of you have seen it. This is apropos of the previous discussion we had. And in that, he talked about how valuable life is as a person, as he is, with the diagnosis of Alzheimer's disease. Welcome, Jim.
Still Here is the Alzheimer's Society's theme for their awareness campaign this year. And this translates well for my presentation today. Even after my Alzheimer's diagnosis 9 years ago, I am indeed still here. Tweet, January 12th. Took Bria for a walk. Didn't get far when I realized I should have put a toque on. What a fool for forgetting that. I sometimes dress inappropriately. More than once this winter, I go for walks without gloves. A few years ago, the Alzheimer's Society had a 1-month Twitter awareness campaign they called In Jim's Shoes, a glimpse of life with dementia. Through this campaign, I shared my personal journal entries about my experiences with dementia. I had hoped In Jim's Shoes might cause some aha moments or provide a sense of confidence for someone experiencing many of the same things. I had hoped, too, it might illustrate to readers there is life after a diagnosis of dementia. Life, you see, doesn't end when Alzheimer's begins. And that is why the In Jim's Shoes campaign was so important. To educate, to reassure, to tell one person's account of his journey with Alzheimer's. My journey started 9 years ago at the age of 58, when I was diagnosed with Alzheimer's disease. It's a strange disease to fully grasp, isn't it? People look fine on the outside, but the problem, the degeneration of the brain, is inside. It's also a disease that has a stereotype built around it. In fact, there is no stereotypical person living with Alzheimer's or other dementias. Everyone has a different journey and will maintain different strengths, abilities, and capacities along the disease trajectory. Some of us drive, some don't. Some are out and about, some stay home. The short-term memories of many are flimsy at the best of times, and we all get disoriented. But through awareness, through compassion, and through stigma reduction, we can build dementia-friendly communities in our own community and around the province. So I'm here today to share a few of my own experiences. Tweet, January 8th. Forgot Alice was getting a prescription and passport photo while I was mailing a letter. When I finished, she was not at the drug counter. I noticed a panic inside. I no longer knew what I was to do. I settled myself down when I looked around the store and saw her exiting the photo area. A car pulled over one day and the driver asked for directions. I couldn't figure out where I was. After what seemed an eternity, I finally identified the street I was on. I then struggled with the cross street. When I got that in my mind, I forgot the street I was on. And back and forth it went. Until I finally got both streets in my mind and got her on her way. She drove off and I was left wondering, again, where I was and how to make my way back home. I panicked, but finally did make it home with my dog's help. And that was the push to register for the Society's Safely Home Medic Alert program. I'm glad I did, because I can still get disoriented in my community and have sometimes found myself on a route I'd not planned to take. Tweet, January 25th. I will not, effective immediately, I will not give people directions. I will tell them I have Alzheimer's and suggest they ask someone else. A fellow was looking for a soccer field. Poor guy, I had him on different intersections. Finally, he said he would drive around and find it himself. I will save the rest of humanity and not give directions again. For 25 years, I worked for CP Air and Canadian Airlines, and during my career, I traveled frequently for business. One particular time at the airport, I went up the escalator and then down. 2 different times. Went right and left on the main floor until I told myself to get a grip. I finally asked for information where to go for my flight and was astounded at my inability to take charge. Now, 9 years living with Alzheimer's, I've come to realize that I have good days and bad days. I suppose the same can be said for all of us in this room, except when I have a good day, it means I can exercise my independence. And when I have a bad day, when my mind is too muddled to do much on its own, it means I need support. For those around us, like my wife Alice, this is an ever-changing landscape of eggshells. For a person who loved business and the accompanying stimulation and who thrived in that environment, I am now very limited in my daily activities to 1 real task a day. Is that frustrating? You bet it is. But my life isn't over. I do have a purpose, like being here with you today, to tell you that we all have a role in creating dementia-friendly communities so that people like me and the guys in my support group can keep on living as well as possible. You see, people with dementia need to get out. We need to socialize. to get exercise and eat well. And sometimes to do this, we need a little push and extra support. Support from our friends and families, but also from our communities, from the cashier of the grocery store, to the bus driver, to the staff at our local community center, down to the folks just out walking on the street. The first step forward to being a dementia-friendly community is dismissing the stereotypes we hold about people with dementia. Like the time at a hospital emergency room when I insisted my wife accompany me to the examining room because I have Alzheimer's disease. A senior nurse in the ER looked me up and down and told me I didn't need Alice with me because I looked fine. And that's part of the problem, isn't it? How is someone with Alzheimer's disease supposed to look? You can't see the generation of someone's brain from the outside. Despite her education and experience, the nurse had displayed a familiar stereotype about Alzheimer's, the one which assumes that as soon as a person is diagnosed with Alzheimer's disease, they immediately become incapable and incompetent. It's pretty obvious to say, but looks can be deceiving. And that is the challenge. And I know we are sometimes going to be a challenge to the people and the services in our community. Which is why I wear this lanyard with the Alzheimer's Society's card. Please be patient. I have Alzheimer's. For me, it's an education tool. I am showing a willingness to talk to anyone about Alzheimer's. And as a business person said to a colleague when he told her he saw someone wearing a lanyard, it's a great way to build awareness and reduce stigma. I advocate to educate, to make the most of teachable moments, to help break the stereotype of a person with Alzheimer's disease, and to help create dementia-friendly communities. As you return to your daily routine, I hope my words and this afternoon's experiences will resonate and stay with you. Because to know a little bit about the disease from a personal level will give you insight and help create a more supportive environment. And with that, I thank you for being here today to hear one person's journey with Alzheimer's.
Yes, you do feel tall standing up here. Thank you very much for having me today to come and speak about the Alzheimer's Society of BC and some of our work. Jim and I have presented many times together, and I am always following in his footsteps. And so I always have a moment of thinking, oh my gosh, what can I go up and say after Jim? Because he tells such a moving story about his experience. But I think it is important for Jim and I to speak and share a lot of information and a lot of beginnings of conversations of how to support families and people who are living with dementia and Alzheimer's, and to think about what that means in our communities. The Alzheimer's Society of BC actually this year is celebrating our 35th anniversary. So back in the early 1980s, a group of volunteers came together, a group of people who said, we need to do something about helping people and helping families who are living with Alzheimer's and dementia. And they formed the society and began to look to ways that they could help families and make a difference in the province. And today, 35 years later, the society is doing just that. Really, our focus is to ensure that we can support families who are living with Alzheimer's and dementia to have the best experience. Our stretch goal, I often say, would be a world without Alzheimer's. But in advance of that coming, and I sure hope that does come one day, we have a lot to do in helping families. Our tagline is Help for Today, Hope for Tomorrow, and that's really looking at how we can help people today and look for the hope that we hope that will come tomorrow with a cure, a cause, something that will change the way that we are being touched by Alzheimer's and dementia. I want, though, to start with a story, and it's a story that a family shared with us in one of the many support groups we do. And this family had just recently begun to experience different difficulties in functioning for the husband, and they had been talking about it between himself and his wife, and they were really beginning to struggle and beginning to wonder what this was about. They really struggled what to do and what was the next step, and eventually they talked to their adult children, and eventually they went to their healthcare professional, their physician, and began to actually start the conversation about what this was happening. And eventually, through a number of reviews and assessments, the gentleman received a diagnosis of Alzheimer's, and the family were shocked. They didn't know what this meant, they didn't know what to do. And as Jim said, just because you receive a diagnosis doesn't mean suddenly, instantly things change. Life was still very much the same. And so this gentleman always enjoyed on Saturday nights going to a friend's house and playing poker. So this one evening, he ventured out in his car to his friend's house to play poker. And at this time, he had not shared anything with his friends about what had been going on with his health. When he was coming home and he was driving home, he began to notice that things weren't looking so familiar. The sky was starting to darken, lights were getting brighter, and all of a sudden he didn't know where he was. So he pulled his car over and he pulled into a gas station, and he pulled out his phone, he phoned his wife, and he said, "You know, I'm coming home, but I don't know how to get home." And she's like, "Well, where are you?" And he's like, "I don't really know." And she said, "Well, can you describe the area?" And he's, "Well, it's a gas station, it's a busy street." So they had a long conversation about what to do. And their decision about what they were going to do was that he would sleep in the car for the night. And he would sleep in the car, and she would know that he would wake up in the morning and call her, and then when it was light and the world was sort of righted again, he would drive home. So that's what they did. Except that in the morning when he woke up, he didn't go home, he went to church. And so she sat at home and she didn't know where he was, he didn't answer his phone, and finally about 1 o'clock he came home. And you can imagine the fear, the anxiety, the stress between that couple. And it wasn't for 3 weeks later that they shared that with their adult children. And you can imagine how those adult children would have heard that story and how they would have felt powerless to help their parents. And that's a real story for what many of our families live with. So the need to talk about Alzheimer's and dementia and start a conversation and let people know that they're not alone is so absolutely critical. First Link is the program that our society runs throughout the province. It's our Help for Today. First Link is an early intervention service that physicians, healthcare professionals can refer their patients. Other people can also refer themselves, self-referrals or family members, to the program. And our office has what we call an early intervention service where people are referred in, and we begin to connect with that family and begin to offer conversations and supports and education. But it's the beauty of First Link, it's all on the timing of that family, because we know that many families can't deal with a lot of information as so much. It's overwhelming. If you're 85 and you're alone, that's overwhelming. If you're 50 and you have 3 kids and you're still working, that's overwhelming. So the beauty of First Link is that our office begins, our staff begins to reach out to families and start the conversation. And we also know that people, when they suddenly get a new diagnosis, it is too much information. And so the beauty of First Link as well is that we continue to reach out to that family, even when they may not be ready to reach out to us. And we keep doing that proactively until that family is ready to take a first step to connecting with a resource. Now, that resource may be ours, and we have 15 offices across the province, and we run a number of different support groups and sessions and a number of different things, but it also might be to another community resource. The key thing is we want to connect that family to help so that they can begin to know they're not alone and they can start that conversation. It is so critical. It is also critical that they begin to have information, and this is what we've talked about, and I'll just go through these slides to bring them all up. Because as we're saying, this is the time when people need the information and need to start the conversation and start making decisions. They're tough conversations, as we heard in the session before. People don't want to talk about this. But this is the time to talk about it when everybody can share their views and express their fears and concerns, and perhaps make some key decisions when a crisis isn't happening, when we're not in a moment where suddenly something must happen and people begin to panic and not know. So society wants to ensure that both families and also community agencies around those individuals have the tools that they need to keep the conversation going. It also is about helping people who are living in care homes. We know that over 80% of residents in care homes have some level of dementia. And for those individuals and their families and the healthcare professionals who are looking after them every day, that can be an extremely difficult situation at times. So the Alzheimer's Society BC has a partnership with Safe Care BC, and we provide training services or training sessions around the province every year to healthcare professionals. And it's really looking at what is person-centered care and recognizing that the best way to support someone who's living with dementia is knowing who that person is. Who is that person first? What do they like? What do they dislike? What is their legacy? Who were they when they were in their sort of their height of their personhood? And ensuring that that is how we approach people, because we know if we approach people from the way that they have always seen themselves, we will have a much better way of providing care for them, and they will have a much better way of enjoying where they live in their own home environment. So training of healthcare professionals to help healthcare professionals is so essential to give them more tools to help them and do the job that they already do very well. We also know that research is the hope for today. So the Society spends a number of, we raise a lot of dollars to support research. We spend a lot of time connecting families, people like Jim with researchers to ensure that researchers have the views of people who are living with dementia to understand what is the best thing that those families need. We often hear what the researchers call the valley of death, which is where the researchers have these great ideas. They go to the lab, they go to the clinics, and they have to be able to flow through these ideas and bring them to the people. And if they don't work for families, then what is the point of research, we often hear people say. So these groups have to come together and have a dialogue and talk about what that means to actually be taking ideas and bringing that to families. And so that is really where the help for today, hope for tomorrow comes through in the Society. But there is a bridge in the middle, and that bridge is again something that's been talked about today, and that is around social change and social impact, which is what we call the dementia-friendly communities. And you heard Jim mention that a bit today. And the idea of a dementia-friendly community is really a community that stops and thinks about how do we support someone to live in a community just like any community member who wants to have a quality of life, safety, accessibility, and continues to contribute in the way that they are comfortable to do that. And so as a community, what do we need to do to ensure that we support people and their families who are living with dementia and Alzheimer's? And it's very much like the example of curb cuts. I love to use that example because we all can remember back when curb cuts came in, I think way back in the 80s, and the whole purpose of curb cuts was for mobility. Today you can stand on a street corner, which all of them have curb cuts, and watch the people who are using curb cuts. And it's people who have mobility issues, it's just people who are looking to walk quicker, it's people with children in strollers, it's people with small dogs. It's become a normal part of our life. And that is, again, the concept of the dementia-friendly community, which is how do we put in changes that become an open, supportive environment for people who may have some challenges. And so the Alzheimer's Society has been thinking about how do you do this, whether we talk about people or policy or practice, and there's ways that can change a community, whether that's a municipality or whether that's like a library. And again, it's important to have that conversation and how to move forward on that. One of the great things of when you think about a community is that communities are made up of people. And so what a dementia-friendly community needs is dementia friends. And that's the role that we all can play. And when we talk about what is the simplest action that anybody can do when you think about how to help someone with dementia is becoming a dementia friend, which is stopping and thinking that there is something you can do rather than seeing a situation that looks awkward or confusing or maybe not someone's in the best experience, rather than walking away and thinking about that, perhaps to stop and say, how can I help that person, and going up and offering some support or asking that person how they could help. That's the real critical part about being a dementia friend. One of the ways the dementia-friendly communities and the Dementia Friends has been so embodied is really exciting in the city of New Westminster. So in January of 2015, we went in and we met with the City Council and the Mayor of New Westminster. Jim and myself and a couple of others went, and we took them through training of what it meant to be a dementia-friendly community and what it meant to be a dementia friend. New Westminster didn't stop at that training. They went on to create a number of different policies and practices within their city, and they now are calling themselves a dementia-friendly community, and they actually have a dementia-friendly policy paper in their city, and they are touting themselves as one of the first Canadian cities to be dementia-friendly. Now that's a real progressive step of a city who is really going to make a difference, and also turning to their neighbors, because we know people don't stay within their city boundaries, and incent people to do the same, or incent their neighboring municipalities to do the same. We have worked closely to ensure that there's information available on housing, on financial, on legal, and again, around all those conversations and decisions that should be made and talked about early on, so that people can begin to start the conversation when they are able to start to digest a little bit of that, as opposed to waiting to a crisis moment. The last story I wanted to finish before I talk about just the Dementia Friend campaign we're doing across the country is really in sort of striking comparison to the story I told at the beginning. So a family, again, that we were very closely connected to, the husband had a diagnosis of Alzheimer's, and he lived at home, and they continued to, he continued to participate in his community and be quite an active member of a number of different things he liked to do. He liked to golf. He loved to drive. He had been a long-haul trucker for all his career. He loved cars, and he spent a lot of time thinking and talking about cars. As his Alzheimer's progressed, he had to give up his license. He began to have a lot of visual issues, and so driving or even understanding how to be on the streets was becoming a difficulty. He eventually had to go and move to a care home because his elderly wife wasn't able to look after him, and his adult children, while they were very supportive, also couldn't continue to support him the way he needed to be. But this family wanted to do something for him. He had been a vibrant member of the community. He had a very long, successful career as a long-haul truck driver, and they wanted to do something to honor him and remember his legacy. So on his 85th birthday, they went out and they bought him the most skookum big four-wheel drive truck. It was bright red, king cab. It had everything fully loaded. And they parked the truck at the care home in the front driveway, and that's where that truck lived. And anytime anybody took out their father to go to the doctor's office, to go to coffee down the street, he was driven in his truck. And it was his truck, and he could look out his window and see that. And that is what a dementia-friendly community does. That is what a dementia friend does. It takes an individual and recognizes what they've contributed to society, what their legacy is, and they look for ways to continue to honor that. And so we really appreciate the opportunity to speak today, because as I said at the beginning, and I think I've heard this several times, it's about starting a conversation and letting families know they're not alone, that we can talk about this and figure out ways to make the quality of life for people who are going through this as best as possible. Thank you.
So just before we talk about really marvelous things, which happen to be late life issues and innovations, and our theme is really looking at a collaborative future for healthcare aides in institutional settings. So a little bit of a different perspective, but very much embracing all of the speakers that we've heard so far. Shall I go to the next slide, Laura?
Yeah, let's do it.
All right, then. We're very, very polished. You'll be amazingly impressed. You are, aren't you? Okay, so my name's Melanie Young, and I'm a registered nurse, and I do have other degrees and qualifications, but for this particular purpose, when we're talking about how I perceive the future and the opportunities for healthcare aides, the RN piece is actually the most important, and it has been very much the most satisfying part of my career as well. 36 years, I know, look at me, you can't believe it. 36 years, I look so youthful. This is what a career in healthcare can do for you. Obviously, I come from England. I trained in the north of England, which is probably one of the best grounds you possibly can. And I've been a midwife, I've worked in acute care, I've worked in intensive care, I've worked in a whole bunch of places, and now I have the honour and the privilege of going into somebody else's home every day and being part of that general management of care and quality of care and humankind that is so much part of our healthcare system. Laura?
I have no experience. I'm still a graduate student. But the World Young Leaders in Dementia Network does span 130 countries now, and we're getting together young professionals devoted to finding better solutions for care and in the future, someday, a cure for dementia. Maria, the Alzheimer's BC, was the one who originally nominated me for this network, and part of the reason I had so much passion for it was because it happened exactly after Gillian Bennett passed. So, Sarah, thank you very much.
So our innovation, you have to bear with me here, is the regulation of healthcare aids in BC. So before we kind of move through a couple of ideas on that one, is there anybody in the audience who is a frontline care aid caregiver? Brilliant.
Ooh, that's an
there was, yeah. Anybody might be?
No?
Hello, we know you, Lindsay.
Okay.
Okay. So then, yeah, okay. So before we start launching into how we might see that, we do want to have a shameless plug, and I wanted to start a flash, but Laura wouldn't let me. And this is where you get to talk about this, because this is your...
I have two slides I get to talk about. December 1st, 2015, we had our first town hall meeting in Qualicum Beach, a dementia-friendly community initiative. We were able to have 2 people from Bruges, Belgium, which is arguably the most dementia-friendly city in the world, come and talk to Qualicum about what happened in Bruges. After that, we had a motion. Town council?
Yeah, so I went to the town council and and did a presentation about what that might look like, and asked for them to make a motion to consider it as a motion. So if anybody's familiar with that kind of bureaucracy, you make a motion to make a motion to make a motion. And finally, we have town council agreement that they're going to give us a hand, give us some support for this rather marvellous initiative. And this is outside of my work at my long-term care facility and outside of Laura's work as a PhD candidacy. Aren't we cool?
Wonderful.
Yes, we are.
Now on to what we're actually talking about. We will be quick.
Okay. So who are care aides? Well, they vary. A care aide is somebody who delivers care either in the community or in a long-term care institution, in some hospitals, and many other kind of healthcare environments. They deliver care that isn't part of the regulated healthcare provider's body of practice, if you like. Okay, you want me to do this? Just over-helping here. Okay. What are the educational requirements? Well, they vary too. So over the last, 10 years or 15 years, there's been a move away from utilising experience, vocational aptitude, these kind of things, towards a much more formal diploma and certification process. But this varies as well. It can be anything from a couple of months to 9 months, and covers a whole range of different types of educational opportunities. So So the takeaway, oh good Lord.
Sorry.
So, my word. So the takeaway is that it really is a variable entry and a variable exit population, where it's quite different in the more regulated professions. All of us, myself included, wear bodily fluids that aren't mine, work weekends and holidays, get screamed at, and the other bit I won't read out loud. Okay? So it's a very hard job. And what I do want to say is that at no time does this presentation suggest that there's any less value. In fact, it's the opposite. I'm really interested in creating a real strong awareness that the care staff, who are basically the folks who deliver care from everybody else's perspectives, all the different organisations that we hear, all of these initiatives trickle down essentially to that moment of care where I'm talking to you as a resident, as somebody who needs care. So everything that we do needs to be able to be designed to be easily delivered at that point. So I just want to talk about the healthcare team for a minute. So the healthcare team is all these folks. So the healthcare team in long-term care, okay? So you see this big blue bit? That's the most amount of folks who are delivering care are our care staff, our care aid staff. The rest are the RNs, the LPNs, the doctors, recreational therapists, and allied health, or your occupational therapists, your physiotherapists. But just by looking at that rather charming graph or chart, it shows you that the bulk of care is going to be delivered by the care aides. And when we talk about regulation, not now. No, it's not the time. There we go. The little group, the colourful little triangle wedges, we're all regulated. The nurses and the doctors are all regulated. But the care aides are not regulated. And I'm going to try and explain why this is important. Okay. So, regulated healthcare professionals, we're supported in our decision making, in our delivery of quality of care initiatives through the Health Professions Act and a whole bunch of other litigation, what's the word I'm looking for? Medical assurances, committees, you name it. It is very, very well protected. And as that group of regulated healthcare professionals, our job currently is to direct care to unregulated healthcare workers. And this causes a problem. It causes a tension because what we're trying to do is deliver standardized practices from high-level quality of care initiatives from essentially hundreds, possibly thousands of places towards a group of folks that are unregulated and therefore perhaps a little unprotected in their own employment place. So there's an impact to the worker. And I'll have Laura talk about this, but my career has been mostly as a manager of people. And that's where my heart's desire really is. I assume that the quality of care that we deliver will be high. It's not where my major focus is. My major focus is making sure we can deliver that high quality of care by having the right person and the right place at the right time. So this is why this regulation piece is so important. This is where you all nod. Okay. So Laura has been doing, as part of a PhD candidacy, has been doing some research, which she's going to tell you about in a minute. And we were able to offer and facilitate care staff to be part of this confidential research project, which is towards the end, but it's kind of what we're basing this on.
It's never ending. So what we're finding in care aides is there's no room for personal or professional growth. Once you're a care aide, even if you have 27 years experience, you cannot go and educate other care aides. You are a care aide, you're a care aide. There's no room for growth. We got that. Hourly workers versus salaried career. They're just an hourly worker. That's how they view themselves when they are interviewed by me. In care aides, you'll notice the blue part of this lovely graph. This is sick time in one long-term care facility. The purple is care aide sick time. The rest is RNs, LPNs. And this is holding into account for how many care aides there are on the floor. So you can see the amount of, 4 to 5 times more sick time in long-term care. There's also huge amount of burnouts, huge amount of injury. 2 to 3 times the WorkSafe BC claims are from care aides than any other healthcare professional. There's also variance in quality of care because we have variance in education and experience levels. So regulation is important because it will better support a standardized quality of care and practice. We already know care aides are the biggest life support for people who are end of life, remembering the theme of the conference, as well as people who have dementia, remembering what panel we're on. So approximately 30% of Canadians die in long-term care right now. Someone earlier mentioned the aging population. This is only going to increase. You can see right now, we talked about this earlier, how people used to die quickly, and now we have a long trajectory of death. So the anatomy of a care aide. I'm very passionate about seeing care aides become professionalized. Care aides are predominantly women. They're predominantly from a low socioeconomic status. They're predominantly women who are visible minority, high-risk, vulnerable populations. And they give the vast majority of care. Studies show upwards of 80% of all direct care in institutional settings, especially for people with dementia, are delivered by care aides. This is a really big deal in case that's not coming across. I forget what that view was. Okay. Oh, now it's my dissertation again. This dissertation will end soon, Gloria. Preliminary results show that care aides feel unnoticed by society and unvalued. One of the questions I ask them is, hey, when you're at a party, what do you tell people that you do? Their shoulders shrug and they're like, this is what people think I do when I tell them. It's not pretty, it's not empowering. How do we expect them to deliver then person-centered quality care? The politics and hierarchy of healthcare. Because there's no hierarchy, there's a lot of bullying, a lot of gossiping. It's not the most professional setting. Not that that doesn't happen in my department.
Oh my.
Yeah. Reduce coping mechanisms, as it gets said before, static professionalism. So some things that care aides have said, the one thing that care aides believe have their back, they do not trust management. They do not trust management. It takes me forever for them to even trust me. In the absence of unregulated standards, the only place workers have to go is the union. Some quotes I've had in my study are, I don't know how the union works. So if they feel that the only thing they have to support them, but then they don't understand or have not been explained to how it works, I feel like the union just makes it harder to get rid of bad care aides. These are all 3 different care aides I interviewed this last year. And finally, the only one who has our back is the union. Taking that quote into context with the other 2 quotes, it's kind of a mixed bag, and they're not supported.
So, as a manager who has dedicated 15 years of my life to supporting workers in the workplace to be the absolute best they can be, to have the safest environment, I really want to find a way to bridge that gap. I really want people to understand that not everybody in management deserves a reputation that they have, and that we're all absolutely focused on the good outcomes for the patient and the resident through the caring hands of the caregiver. So I look at as a general manager with a nursing bias, obviously, I'm also looking at the finance departments, at the outcomes of this. So the cost of recruitment and re-recruitment, we've already spent just in our facility quite a lot of money. I'd love to give a number, but I'd be shot. Quite a lot of money already on orientation. So we recruit somebody, the care aide then comes and becomes part of our employ. We work a lot around employee engagement and employee wellness. But over time, when all the factors that Laura's talked around about opportunity for career succession, career planning, that you can start and end your career on the same hourly rate, you become disengaged. The ideas that you had about your role changes and diminishes, and so often the care aide leaves. If the care aide's not leaving, they're going off on a sick program or something like that, and I actually understand why. I get it. There's no judgment in there. I understand how it works.
And bringing this back all to persons living with dementia and people who are end of life receiving the vast majority of care, this takes away from care. If it's constantly a cycle of recruitment, disengagement, you get where we're going. Thank you.
Yeah. Unfamiliar faces providing care on a daily basis, and that's just not how we want it to look. So from an innovation perspective, outside of our work, my work in the workplace and Laura's work, and our work with dementia-friendly communities, we're just embarking on some relationships with the BC Care Aid Registry, with the College of Licensed Practitioners and Licensed Practical Nurses of British Columbia, and a little bit with the College of Nurses of British Columbia as well. We're right at the beginning of this because it's been a really long time to be able to have these big conversations. But because I think the expectations and the attitudes towards death and dying and dementia care is changing, which is just remarkable. I think it's a really good time to start having the conversation about who's also providing the care and what their needs are as well. And we haven't got the link to YouTube.
Well, I guess the YouTube
We
video
could
isn't
sing.
happening.
Yes.
No, honestly, it's really a bad idea.
That's it.
Yep, that's it.
That's it. Come talk to us later.
Climb over the chairs.
Well, thank you very much. We do have time for questions. Your comments were reminding me about two studies that I was involved with at UBC with Michael McEntee in the Faculty of Dentistry. And one of them was related to working with care aides and trying to encourage them to improve the oral hygiene for people. And then the thing that we learned in the study was they didn't value oral hygiene for themselves.
Yeah.
And so we recognized that. Another study we did, well, okay, how can we provide an educational program for the care aides? And so we said, well, you have to be somebody in the care facility. Well, as you implied, the relationships between the care aides and the nursing staff are not that great. So even if the educator is the nursing staff member, there still are these difficulties. And furthermore, we learned that there's an incredible culture within the care aides themselves, and they say, we know how to do things, we don't want to hear while you're doing it. So this is a really important area that you're working on and looking at, because it could be you and I in the nursing home and this care aide with all of these issues going on, and I think that there are many challenges and many stairs to climb in order to overcome some of these difficulties, which are being recognized, but it's very challenging. I want to thank you both very much. Obviously, you struck a note for me. Also, Maria and Jim are talking about, how we keep dementia out there. And when you have people in care facilities who are demented, and then we have all of these issues, how do we make it dementia friendly in the community and care facilities? And I think that's an extraordinary challenge. And Maria, have any care facilities wanted to be dementia friendly communities?
Oh, absolutely.
Good.
Yeah, no, they recognize that is a really important dynamic.
Can we have microphones around? Are they on?
No, I think there are a number of care facilities across the province who recognize that they have to find a way to make their facility, or not facility, their care home, a safe and accessible place for people living with dementia, and have a person-centered approach to how they are doing that.
And okay, let's open for questions from the floor.
Hi, my name's Derek, and I have a question for Maria. I know a person who has concerns that she has dementia. She's brought it up with her doctor, 2 doctors now, gone through the typical, what day of the week is it, fill in the clock, that type of thing, and in both cases is told that she's fine. So, and yet the concern lingers because she's getting more forgetful and she gets confused. Where does the person go after that? Or is there a place? I mean,
it's a tough journey, and I think the experience that you share is not unusual to what we hear, and there are so many factors that come into play. We know that a lot of people experience cognitive changes that aren't related to dementia and Alzheimer's, and sometimes in their conversations with their physicians, it's a process of elimination of other things that are going on. I think the important thing is to keep the conversation going. I don't think it ever hurts for families who are feeling frustrated with what they're experiencing, and maybe the response from their physician is maybe not the one they're hoping for, to continue to, you can always phone the Alzheimer's Society. We have a dementia helpline where people can phone and have those conversations and get connected with other resources. It's always fair to ask another physician to talk about, but I think the important thing is to keep the conversation going and make a note of what the changes are. It might be interesting, Jim, to ask you what your thought on that would be and what families and people could do to pursue that.
Well, actually, your last comment is what I would encourage very strongly, is to sometimes it really is the lived experience, and to actually have an appointment with the doctor, and at that point focus the conversation very, very directly by putting a piece of paper in front of the doctor and saying, between the last appointment and now, these various incidents occurred. They are extraordinary, they are unusual, and they are concerning. And while the doctor at the first appointment may well acknowledge that and try something else, I think you do that 2-3 times, and your point's made. And I believe that sometimes it's not necessarily the memory test as much as the proof, and that's what I would encourage.
Thank you both.
And I think your point is so correct about going back again. You know, my doctor didn't pay any attention, so to heck with it. But you have to go back and you have to persist with letting them know what the complaint is and how it's affecting function on a day-to-day basis, the incidents that you talk about.
That's what I did with my mother. That's how I know it works, really.
Other questions? Yes.
I had 3 questions, one of which has sort of been answered there, as to there was to Jim about how you first recognized that you thought you had dementia, and what brought that to your attention, that, hey, maybe I've got that. Is it strictly the doctor's test, or whoever does it, by giving you a list of 10 things and then 2 minutes later asking you what they were? Is it a memory test that they give you, or is there a physical test they can give?
I had insight into dementia because my mother was still living at that point, and so I was her caregiver. My wife and I were her caregivers, and so I saw the disease, and so I had the insight. But for me, there was a 1-week period in January, the month before I was diagnosed, where I had 3 incidents, one right after the other, that one of them was being lost in an airport, that were significant, and consequently that's when I went to the doctor for the second time. I will say that the first time, as I was leaving the doctor's office months before, I said that he and I needed to chat because of my memory problems. So then I went back with that piece of paper with the items noted, and we went from there. That was my family doctor, and then I did go to the Alzheimer's clinic at UBC and had further testing to confirm it.
I think it would be important to add, and you know, we hear often people say, well, what is the difference between dementia and Alzheimer's? And it's an important sort of distinction to make, because dementia is not a disease itself. It's a collection of cognitive changes or limitations. Alzheimer's is a disease and is probably the most prevalent of dementias. But I think, and Lynn, you might be able to correct me on this, but I think there's over 100 different types of dementias. And they all manifest themselves differently, and even as Jim said earlier today, one person with dementia is one person with dementia. And so while there are tests that people can go through and their physicians can have them participate in, that doesn't necessarily mean it's going to identify a specific thing. So the need to have conversation, and as Jim is suggesting, to keep sort of a watch on for you, what is your change in behavior, which is not usual for yourself, is really important for your physician to understand what is happening.
So there isn't a saliva test, a DNA test, or something of that sort. It's more just your ability to have a memory of things.
It's really the story. I think that in my years of listening to people with their problems related to presentation of dementia, it's a story. So everything is important. It may have been in the airport. It may have been putting the ice cream in the cupboard, then they usually put it in the freezer, and those sorts of things. And all together, when you hear the story and the accumulation of these incidents that you can write down, and I always think Jim's amazing because he can remember all these problems that he had. He does write them down, but I think that's really important. And there's no test that's a substitute for the story.
And I've forgotten what my third question was. I'll come back in 15 minutes and tell you.
Hi, a really interesting panel. I've known several people in several different kinds of circumstances, and one thing I've noticed is people who are idiosyncratic are sometimes labeled with dementia when it doesn't seem to be that way, and I'd want like an opinion about that. Like a lot of older people they do something that's like off the beaten path, that they are considered, if they're late, or they are told that they may be demented. The other is, question I have is, are there any behaviors taken by caregivers and family that are actually help to improve the situation for people who are experiencing Alzheimer's and dementia? Things that really work to make life better for those people under your care?
I think that for the first statement about dementia, if you have silver hair, that's ageism.
Yes.
It's just flat out educate yourself. You can call it ageism, I do.
I'm really hoping that it's not idiosyncratic behaviour, because I qualify right now. Okay.
But the key is the change in behavior. You know, if you were always idiosyncratic and you're still idiosyncratic, you're okay.
Thank you.
But if you're no longer idiosyncratic, we better watch out.
And the last part of the question was that caregivers around what can caregivers that can help?
How can you help?
Oh well, I mean that could now go
The
on
top
for about
three.
2 hours. So the thing that I think caregivers can do is really promote and advocate for the person that they know that person to be. So whether that's a family member or whether it's a caregiver, a care aide who's been working with a resident known them for 5-10 years. That can sometimes be that length of stay. They're the right people to ask, not me.
I think, again, stories tell a lot. And we had a story of a family whose father was admitted into a care home, and mealtime was just so difficult. And they couldn't get him to sit quietly at the table, and it was always a real just a real struggle, and then of course that was a real disruption to other people, and the staff at the care home just couldn't figure out what they could do to have him calm down and eat, and they were trying to even consider having him eat in his room in isolation, which isn't great. And so at some point they asked the family about why this behavior might be going on, and the family weren't really sure, but the one daughter said that he had grown up in Britain and he had always been a true gentleman, and in his era a man would have never sat down at the table until all the women were seated. And so what they did at that care home is that they made sure at every meal before they began that every woman was sitting down in a chair, and then he sat down and he enjoyed his meal. And it's a perfect illustration of understanding who that person is and what was unique to him. And by looking at the person first, as opposed to their limitation, that was just a wonderful way to honor both that individual and everybody around. So it's a story that tells.
Thank you. Next question.
Yes, I'm very glad that you bring out the issue of regulating the care aides. The care aides are very important part of the entire long-term care, because apart from, they provide the majority of long-term care, they are the frontline workers. The frontline workers, they have direct contact with the the person receiving the service. So their attitude, their behavior, and how they manage their work, their service is very important. Are they responsive to the calls? That kind of thing. So how to encourage them to stay in the profession, how to avoid burning out is one thing that can be considered in your regulation, in your making the regulations, like creating incentives. That is something that really can be considered. The other thing is about people, not in this country, but in some other places, just like in Hong Kong, the care aides abusing the people receiving service. And the case have been brought to court. So how we need to prevent these things from happening in this community. So would you be considering some sort of measure along this line?
So how do you value, are there some ways to value the caregivers?
That is such a big question, because I mean you can go down typical employee wellness models of, you know, make sure that we've got enough staff and you've got enough supplies and enough equipment and enough people so that you can take your vacation and you can do all of those kind of things, that they've got enough mechanical lifts. But what we've found during Laura's research is that it's a much more profound reason for being engaged or not engaged in the workplace, and it really is how they feel as a valued or devalued or undervalued member of the care team. And that's where, when you've got a whole bunch of folks who are completely regulated and fall under this professional umbrella, and the majority of the caregivers who fall outside of that, there's going to be a natural tension, problems with trust, problems with accountability and responsibility. So it's bridging those gaps to bring people into the circle of care who are actually doing the care that will provide the greatest value and meaning, I think.
So care aid-centered care for patient-centered care.
Letting the care aides care was the other title for this presentation, and recognizing that they are most often in long-term care the place that you would look first for your solution, and really embracing that.
Jim, did you have a comment?
I think too, in the case for residents with dementia, I think a better understanding of dementia and dementia care would go a long way. Mm-hmm. And I guess to use a story, choice can sometimes be an issue for people with dementia. Like you could open a clothes closet and say, here, what outfit do you want to wear? And that will cause some problems because you're giving too much choice. So care aides, when my mother was in residential care, some would go along with a big tray of cookies at coffee break time and say, here, have a cookie. And my mother would always then say, I don't want a cookie. But if you had the tray and some care aides would take a cookie and say, here is your cookie, my mother always took that, and it was always her favorite. So it's one of those little things of caring, of care in understanding dementia care.
Very good point. Question here.
Thank you. I'm confused. Is that a symptom of dementia? Did I hear you say that there was a high turnover of care aides?
Yes,
that's right.
Okay. Who determined, beg your pardon, what's the criteria required to become a care aide?
Were you not listening?
That was one of our slides. Good grief. So just in case you forgot, it varies. It really does vary. I have got a phenomenal care aide. That sounds very possessive. I don't mean it to sound like that. But we have a phenomenal care aide called Gail, who's been a care aide for, I can mention Gail. She said I could. for over 20 years, and she entered into this profession simply by seeing it as a vocation and has learned her skills, her vast skills, over that time, and has been able to be accredited with the BC Care Aid Registry, which is part of our employment requirements. And then I have a young lady who is brand new out of a 9-month diploma course. So we have both, and both are equally valuable, certainly in my observations, for sure. So it really does vary.
Do we have to wrap it up, Gloria?
I guess part of my question is, does the government not set any kind of regulations in terms of the qualification of care aides?
I would love to have a conversation with you offline on that one, because I think we're running out of time. Yeah, there's all kinds of different ways of approaching it, and we just need to be sure that
But the government has no hard and fast set of criteria.
Oh, absolutely, they do.
Thank you.
Yeah.
Well, I want to thank our panel very much. Did you have just a quickie?
Yeah, really quick. Really quick comment. I'm Elizabeth Dunbar, and I sit on the BC CARP caucus. And one of the things I do want to just tap into with everybody is that, dementia, as has been mentioned, is a syndrome, and there's a lot of conditions that lead up to dementia. So what we're finding more and more is it's no longer about aging or getting older and that sort of thing. I'm in touch with people daily, 23 years old, 32 years old, 38 years old, that have the syndrome of dementia. So I just want to put that out there to people and start getting rid of some of the prejudice around it's grandma or it's mom forgetting to close the door.
Thank you for that.
I wanted to put that out.
Well, thank you very much, because stigma is really acknowledged as one of the big issues that people deal with. Again, I want to say thank you very much to our panel, and I want to say thank you very much for being such an attentive audience.